I'll get started. It's just after 12. So miigwech and merci beaucoup, and thank you for joining us today for our Health Sciences webinar on Rehabilitation Care Alliance. It's delivered by Carissa Levy, the Executive Director of the Rehabilitation Care Alliance, Katie Churchill and Gabrielle Sadler, the Project Managers for the Rehabilitative Care Alliance. I'm Jennifer DeBaker, and I am the Health Sciences Programs and Partnership Coordinator here at NOSM University. Before we get started, we'll do a quick welcomes and introductions. So just a reminder about your microphone being off for the duration of the webinar. It is being recorded today and will be posted to our RS and NODIP websites in the future. If you have any questions throughout the presentation, please feel free to put them in the chat. We will have a dedicated question and answer period at the end of today's session where they will answer any questions that you may have. And all of our previous webinars are on our RS and NODIP websites in the resource section. So in the spirit of truth and reconciliation, NOSM University respectfully acknowledges that our Pan-Northern campus is on the homelands of the First Nations and Métis peoples. The university buildings we occupy in Greater Sudbury and Thunder Bay are located on the territory of the Anishinaabe Nation, specifically Atikameksheng and Wahnapitaea First Nations and Fort William First Nations. Beyond a land acknowledgement, we understand that reconciliation is a practice. We gratefully acknowledge the elders and knowledge keepers who share their gifts and teachings with us so that we may better understand and honor their wisdom and that of all the traditional keepers of this land. NOSM University will continue to practice reconciliation by listening, learning, and fostering a cultural and mutual respect and trust. Our speaker today is Carissa Levy. She is the Executive Director of the Rehabilitation Care Alliance. She provides strategic and operational leadership, engaging with diverse partners in identifying issues and implementing collaborative, evidence-based approaches that drive improved health services at regional and provincial levels. Carissa is an occupational therapist and holds an appointment as an adjunct lecturer in the Institute of Health Policy and Management I can't speak today, evaluation at the University of Toronto. Katie Churchill is the project manager with the Rehabilitation Care Alliance, and Katie is passionate about advancing best practices and using evidence to drive decision-making at a regional and provincial level. Katie is an occupational therapist and holds an appointment as an adjunct lecturer in the Department of Occupational Sciences and Occupational Therapy at the University of Toronto. We also have Gabrielle Sadler. She's a project manager with the Rehabilitative Care Alliance, leading initiatives that support and implement of quality rehabilitation care across Ontario. She has completed a master's certificate in healthcare management and is a certified Lean Six Sigma Black Belt in healthcare delivery. Gabrielle is a physiotherapist and is a current chair of the Canadian Physiotherapy Association Seniors Health Division. So merci beaucoup, miigwech, and thank you. Carissa, Katie, and Gabrielle, thank you so much for sharing your time today. And we very much look forward to your talk and look forward to asking questions. I'm going to share my screen.
Great. Thank you so much, Jennifer, Mike, Dana. Appreciate that, and really appreciate the opportunity to speak to everyone today, and looking forward to the question and answer period. Our presentation, we really wanted to just raise awareness of the Rehab Care Alliance, knowing not a lot of people know about us, even though we've been in existence for 10 years. Hard to believe. And really just provide a high-level overview of some of the initiatives that we're working on, and let you know about opportunities to become engaged in our work. So I will start us off and provide a little bit of background on the Rehab Care Alliance, and then turn it over to Gabrielle and Katie, who will speak to some of our current initiatives. So as you can see, the Rehab Care Alliance, we are a provincially funded project management secretariat. So we have one other project manager who is with us, works with us as well. So we have 2.5 FTEs. I've been told we're small but mighty. And we work with provincial partners to strengthen and standardize rehabilitative care. You'll see we have initiatives focused on best practices, on system evaluation, on looking at opportunities to really bring forward the value contribution of rehabilitation across the care continuum. And we do that by engaging with clinicians, researchers, professional associations, and people with lived experience. So we can go to the next slide, thanks. And I know this is a rehab audience, but I think it's always important to recognize the diversity of rehab professionals and all the value that they have to bring to the clients that they serve, and recognizing that they're really key partners and key aspects of an interprofessional team approach. As we all know, rehab providers are employed across the care continuum, hospitals, community. They work with everybody across the age continuum in schools, primary care, long-term care homes, and that really work to support goal-directed plans with clients and families that maximize cognitive, physical, communication, and functional abilities. And thank you, dietitians, also important to recognize. I appreciate you mentioning that as well. And working with individuals that have a variety of rehab needs. It could be as a result of an injury or an illness, prevention, chronic disease management, or issues to address frailty. And it's always important to highlight the benefits of rehab as well. We know that rehab plays a really key role in supporting both clinical outcomes as well as health system objectives. If we're thinking about older adults, rehab plays a key role in supporting older individuals to remain at home by optimizing strength and balance, addressing cognitive issues, working with caregivers to support management strategies. And we know that rehab plays a really important health system role as well, because individuals who receive rehab can benefit by not requiring as much personal support or ongoing supportive care needs, which has been shown to reduce costs over the longer term. Rehabilitation is an important thing to consider as well for older adults. When we look at the data, we know that falls account for 81% of injury-related hospitalizations for those that are over 65. And rehabilitation that's provided through things like fall prevention programs and other services in the community really help to minimize associated healthcare costs, but also help to support patient outcomes in the community with chronic disease prevention and management for things like COPD and CHF. And thinking about surgical recovery, which is also top of mind coming out of the pandemic, rehab plays a really important role in supporting individuals after surgery, but also in providing self-management approaches and potentially avoiding the need for surgery in supporting improved function and mobility, strength, and range of motion. And so as we look to the governance structure of the Rehab Care Alliance, you can see that our vision is that patient and system outcomes are optimized through the integration of rehabilitative care at all levels of health services policy, planning, and delivery. We report into Ontario Health, and you can see we have a number of initiatives there, but we have just chosen a few for you today given our time. So we will be speaking to our work in the area of older adults, our performance and system evaluation work, our focus on community-based rehab, as well as our workforce task group. So with that, I will pass it over to Gabrielle, who will start us off with a focus on our older adult initiatives.
Great, thank you very much. I'm really excited to be able to share with you some of the work that we've been doing here with our older adults initiatives, and have to say that Thunder Bay has been a really big contributor to this work. And so as we go through this, we'd love to share a little bit with you about some of the things that we've been doing specifically with Thunder Bay as we're moving forward. And I should say really the Northwest as opposed to just Thunder Bay, as I know that there are many of you from surrounding areas as well. So really, there were two main focuses of this work. The first was to disseminate, support, disseminate and support implementation of the RCA PGLO best practice framework that was recently released. And this framework has provided a standard of care for older adult rehab. So we know we have lots of other standards of care, right? Like, so for total joint replacement or for stroke. And meanwhile, we really needed this. Oh, thank you, Carissa. Yes, PGLO is Provincial Geriatrics Leadership Ontario. Sorry, glad you caught me on that. So basically what we're needing to do is then be able to say this is what is best practice for providing rehab for older adults. And so we have worked over this past year with both PGLO as well as NESGC, which is the Northeast Specialized Geriatric Center, to develop implementation planning and resources such as a gap analysis tool, as well as other handouts for what you can do next. And so then we also have been moving into providing a series called our Facilitating Implementation Conversation series with those kind of early adopters, so those regions who were really interested in implementing this standard of care with this best practice framework. And so Thunder Bay and surrounding regions have been one of those early adopters that are participating in this series. We also have developed and implemented a webinar learning series. And so this series is really looking at implementation from different angles. And so if you go to the RCA website, you'll be able to actually look at this series as it's all been recorded. So if that's of interest, please feel free to go and take a look. And eventually what we'd like to do, hopefully this fall, is to host a showcase to share these learnings and just spread the work that's being done. So next slide, please. Great. So I just wanted to share a very little bit about what we've been doing in Thunder Bay. And so I have shared these slides with permission from our Northwest Regional Rehab Care Program and Northwest Regional Seniors Care Program. And I see Denise is on today. So Denise, if you can take yourself off mute, you are welcome to chime in at any time if I've missed something. So, but the first thing is that we realize that we really need to take a look at the path that older adults take and recognize that it's not linear. Okay, so people can kind of come on and off this path at any period of time, and right throughout their journey they are requiring rehabilitative care for them to be able to move forward with their life, for them to be able to live the quality of life that they would like to live. And so we really needed to look at this because it can be very complex. It's not simple. And next slide, please. And so when we look at the population profile for, and this is in the Northwest, we can see that we have a definite increase in our projections for those older adults who are living with frailty. And so this is something definitely to consider, because we know that frailty, you know, sometimes people think of frailty as something that can't be turned around, and we know that it can, right? And so we need to be looking at this and seeing, how do we affect these projections? Next slide, please. Okay, so this is an important piece, because these diagnoses that you see here, so awaiting placement, dementia, delirium, falls, weakness, frailty, COPD, and Parkinson's, they make up 7% of all cases that happen within our case mix groups. Okay, that's 20% of all bed days, but that's 57% of all ALC days. So if we can affect these particular diagnoses, which are really, as we know, and I know a lot of you on here are our rehab colleagues, all of these diagnoses fall in that spectrum of geriatric syndromes. So if we can affect this through rehabilitative care, we can affect that 57%. Okay, next slide, please. So what have we done? Well, we convened stakeholders from right across the continuum, again, in Thunder Bay and surrounding areas. And then what we did was we process mapped the journey of an older adult across the system. And it was quite a complex process. And I've just been so amazed at the work that the partners have done here to really look at what is this journey. And then what we did was we looked at clinically what happens, and completed from that input the rehab care gap analysis, as well as the ALC leading practices self-assessment. Next slide, please. And so what we found were that there were certain gaps we need to look at. So we need to look at the early identification of older adults. Let's catch people before they're heading down that slippery slope, right? We need that collaborative pathway. We just talked about how complex this is, right? So let's look at how can we get this pathway both to inpatient rehab as well as to outpatient rehab. We need geriatric expertise in the standard of care in the emergency department. And we need a documented care plan that spans the entire interprofessional team, and processes of care that also lead us to be able to work towards this standard of care. So we know what these gaps are. Now what we need to do is to really assess those change strategies, and what are going to be the barriers to being able to move forward, and what are the facilitators, and then develop an implementation plan. And this is an amazing team that we know is going to be able to move forward. The second part is primary care and ED post-fall pathways. And so many of you know that this was also rolled out in Thunder Bay. And so this is really catching people. So we know that the fall, an older adult that falls, that's often that tipping point on that slippery slope towards functional decline and frailty. So to reduce that and to improve patient outcomes, we have to look at secondary fall prevention pathways that integrate rehabilitative care. And so what we went ahead and did was to develop these pathways based on a comprehensive literature review, extensive input with subject matter experts right across Ontario, Canada, and even into the States. And then we piloted this in Hamilton, Sudbury, and Thunder Bay. And we're currently implementing this in OHTs and regions that have expressed interest across Ontario. So in Thunder Bay, we were able to move through the entire pathway, or the entire pilot. And what we found was that, first of all, most clinicians rated this somewhat to very effective, which I was really excited to see, because for something to work, it has to work for the clinicians. We can't be giving them extra work and then it's not actually working for them. So, you know, there was more attention brought to rehab and those risk factors. More comprehensive assessments were done, and there were more referrals being made, more options for fall prevention, and at-home visits were then available because of the pathways. Next slide, please. So this is looking at something called the EQ5D5L, which is a patient-reported outcome measure that really measures a person's health status on 5 different domains, which include things like pain and mobility. And so you can see here that there was a significant improvement in at least one dimension from the beginning, when they presented to primary care or the ED, to when they were done their rehab care. So that's really exciting to see that this is showing out in the data. Next slide, please. So as well, on that EQ5D5L, they rate their overall health status on a scale of 0 to 100. And the minimally important difference is 7 to 10 points. And what we found that in that pre to post, we were actually 9.7, an improvement of 9.7, which shows that there was definitely an improvement. Next slide, please. We also saw an average overall rating of 6.2 on a Likert scale of 1 to 7 for patients who rated their experience by answering this question of, I am likely to recommend this service to friends and family that need the same care. And so we really saw comments like they were pleased with the services of the geriatrician, fall prevention. Overall, it was a pleasurable experience, and that staff responded really well, and that the staff wanted me to come to the ED earlier, but I felt like I was okay at the time, and then the emergency department still treated them so well. Next slide, please. So what's our next steps is we're going to complete the series. We're going to showcase the learnings, as I said, in the fall. We're actually working towards the launch now. As I was talking about primary care and ED, now we're looking at this pathway with a launch, or with an entry point from paramedicine. So we're working in Thunder Bay, again, is one of our pilot sites that's looking at this pilot to have this entry point into the post-fall pathway from paramedicine. So that's exciting. We're also going to look at spread and scale of the ED and primary care post-fall pathways to other interested regions. And we're currently looking at updating the process to admitting to inpatient rehab directly from the emergency department and community. And on to Katie.
Thanks, Gabrielle, and thanks, everyone. Now we're going to switch gears a little bit and talk a bit about some work happening in the system evaluation world. So the objective of this is to standardize the evaluation of rehab care services at the regional and provincial level, and to support evidence-based practice and system-wide improvements. So over the year, we have a number of initiatives underway to help advance this work. The first one is with the release of an annual performance report. This is really a large bucket of work where we look at how are things going in the rehabilitative care context. What we do is we publish the annual report, which consists of 14 indicators, and I'll share a little bit more about those indicators. We also have a really interactive dashboard that then hosts all of this great data, where people can go in, look at the data, look how they're performing in their region. You can look at provincial performance, and you can drill right down to site level performance. We're going to be enhancing this work over the next year through the inclusion of outpatient rehab data. So it's going to be an advancement in that area, which is very exciting. And we're also going to be pulling in some data from a rehab provider experience survey that we've been collecting to really round out, the quadruple aim approach to care. We also are going to be advancing work with respect to a quality improvement project where we're launching a self-assessment tool focused on supporting transitions from hospital to in-home rehab. Next slide, please. So a little bit more about our system performance dashboard. This dashboard is available to anybody in Ontario who has a hospital-based email account or a home and community care email account or associated with other organizations. So this is a tool that's hosted on the Ontario Hospital Association webpage. You can see the URL there on the screen, and you can log in and actually access all of this great data. If you are having any difficulties with getting access, don't hesitate to reach out. There is sometimes a bit of a lag between when you register with the OHA to when you can actually access the dashboard, but I really encourage you to do this if you haven't already done so that you can get in there and have a peek at the data. Next slide. So within that dashboard, we have a number of different indicators. I mentioned that they were aligned with the quadruple aim, and we'll go through that in short order here. But I also want to point out that we're actually shifting gears to expand that into the quintuple aim, which is the addition of an additional domain, which includes health equity. So the first domain that we're going to talk about is patient experience. And in that dashboard, we have 2 different patient experience indicators that you can check out. The first time is wait time for inpatient rehab. And when we're looking at inpatient rehab, we're looking at high intensity rehab, low intensity rehab, and also activation or restoration rehab that may happen in a convalescent care program bed. We also have wait time for in-home rehab, and that's based on the patient availability date. In our next domain of population health, we have patient volume data for inpatient rehab. We have patient volume on activation restoration beds and convalescent care, and we also have in-home rehab volumes. Another indicator that's available there for you is your average admissions score with respect to the FIM for each of the different rehab client groups or RCGs. We have an indicator on the rate of repeat ED visits for falls among older adults age 65 and above, and this really ties into some of the work that Gabrielle was just speaking about. We have another indicator as well that's the number of fall-related ED visits and rate of admissions per 100,000 for people 65 years and older. Next slide, please. In addition to that, we have value and efficiency domains where we can look at ALC rates in both acute care and in inpatient rehab. You can look at ALC rates in rehab by levels of care. And we also have an indicator where you can look at the percentage of acute ALC designation to high and low intensity rehab within 2 days of admission. So further to that, we now have our new provider experience data. This new data has come about with the launch of our rehab provider experience survey that we completed in the fall of 2022. That data is not available on the dashboard just yet, but we do have a summary report that is posted to our website that you are welcome to check out. Oh, back one more, I'm just almost done. Thanks, and the last one, as I mentioned, go ahead, one more, Jen, is the health equity piece. So as I mentioned previously, the dashboard and the system evaluation work was aligned with the quadruple aim, and now we're actually shifting gears into a quintuple aim, and we're going to be including health equity data in the near future. Next slide. So here's a quick snapshot of that dashboard as I was talking about. Here on the screen, you can see a regional data example. I've pulled up the Northwest. You can see there in the filter. This is just, again, a quick view of that wait time for inpatient rehab from acute care to a rehab bed in that Northwest region. As you can see on the slide there, pardon me, the wait time for high intensity rehab was 9 days in the Northwest. For low intensity rehab, it was 8 days. You can then compare the performance of that regional data to a provincial rate, which you can see there is 7.2 on the screen. And this one is actually an indicator that has a benchmark of 3 days. So in all the little circles there you can see on the screen, on the actual dashboard, you can hover over those circles. You can see which sites or which regions they represent, and you can get a lot more information when you go into that dashboard and hover and start to check it out. Next slide. Another example I wanted to share with you is around ALC rates in acute care to inpatient rehab. Here for this example, I've pulled up the Northeast data, as you can see on the diagram on the right-hand side of the screen. In this indicator, it's looking at measures of usage of acute care beds for patients waiting for inpatient rehab by measuring the total number of ALC days contributed open and closed cases over the total number of acute inpatient days. So it's expressed as a percentage. And in this example, you can see in the Northeast, although there was a slight increase from 5% up to 6%, it represents a change of about 22%. Here again, we can compare that to a provincial rate, which was at 3.7%. So just some next steps to highlight with respect to the system evaluation work. We've just released the 2021-2022 data that is now going to be available on the RCA website. In the next year ahead, we'll be working on the next year's worth of data with, again, an updated summary report and an updated dashboard. We're going to continue to advance the work around the inclusion of outpatient and community clinic data for hip and knee arthroplasty. And as I mentioned, we're going to be starting to include rehab provider experience data as well. As we shift into that quintuple aim, we're really going to be trying to bring an equity lens to the data to help identify, measure, and address inequities in rehabilitative care. As I mentioned as well, we're going to have another release of our rehab provider experience survey in the fall of 2023, and we'll progress the work of our rehab transition self-assessment tool to support those transitions from hospital to in-home rehab. Next slide. Shifting gears again, I'm going to talk a little bit now about our workforce initiative. This is another big bucket of work that's been underway for the last year. The objective of this work is really to bring provincial partners together to lay a foundation for building a workforce strategy that's going to be focused on the greater recruitment, retention, and experience of rehab professionals across healthcare settings. In our first year, we were really trying to bring the stakeholders together to explore the different issues that we're hearing about. We also conducted a very robust environmental scan, looking at workforce strategies, but also understanding sort of the current state of rehabilitation workforce in Ontario. And we're starting to identify potential models of care and opportunities that we could be looking into to support the greater recruitment and retention of rehab professionals. Next slide. So as I mentioned, we've been working with all these great stakeholders from across the province. We've had representatives from professional associations, academic institutions, leaders and frontline care providers who've been really helping us understand what is the current context of rehab workforce issues across the province. A lot of the discussion has been focused on rehab provider experiences. We've heard a lot around retention issues and also recruitment issues that have been impacting not only the rural and remote areas as they once were, but really all across the province. Through this work, Chris and I also had the opportunity to present this at the Canadian Health Workforce Virtual Conference in December, which again was a really great opportunity for us to sort of shine the light on rehab. There's been so much focus in the media around other healthcare providers, and we really feel it's important to elevate the profile of rehab. With respect to the environmental scan, this is in the final stages of being posted on the website so that everyone will be able to access it. But again, just an opportunity to really understand what is the current state of workforce issues for rehab in Ontario and start to explore some of the strategies that we'll be looking at in the year to come. Next slide. I would like to highlight one really innovative strategy. This was shared with permission from Denise Taylor. So again, thank you so much, Denise, for sharing this example. I think it's just a great way of, really, illuminating the opportunities and the unique ideas that are happening in the province. So this community rehab worker role was developed through a collaboration with the St. Joseph Care Group in Thunder Bay and the First Nation partners in the Northwest. The Northwest Rehab Capacity Plan group identified significant gaps in rehab services throughout remote Indigenous communities in the Northwest. They identified that elders were at risk if they needed to travel outside of their community to obtain necessary rehab services. And they felt that those rehab services were so important to help support transitions from hospital to home, support healthy aging, and improve quality of life and decrease the impact of chronic disease. The Community Rehab Worker Program trains local community members in rehab principles and skills to provide services throughout the home and community care program. This is a really innovative program, and thanks again, Denise, for sharing this with us because we feel it's one example that really should be profiled. And with that, I think I'm turning it back over to Gabrielle.
Thanks, Katie. Okay, I think this is the last initiative that we're sharing today, and this is our community-based rehab initiative. So I know many of you here, as I said, are rehab professionals. I don't need to talk to you about the value of community-based rehab, but I am afraid that there are many decision makers out there that we do need to get this word out. And so that's what this one is all about, is really to increase awareness among OHTs and decision makers of how community-based rehab care models can enhance patient outcomes and really support better flow and improve patient transitions. So first of all, we wanted to identify actionable short-term recommendations that can be taken on by OHTs, and then to disseminate a briefing note to OH and the Ministry of Health, and then a resource document that can accompany this briefing note that could be used by Ontario health teams. So next slide, please. And so that's exactly what we've done. So that briefing note was finalized and disseminated a few months ago to Ontario Health and the Ministry of Health, and then we are just about to disseminate the resource for OHTs, which includes recommendations for OHTs, so how they can actually implement the higher level of recommendations that went to OH and the Ministry of Health, and then to also give them examples of innovative models of community-based rehab, because sometimes that can kind of get your juices flowing to actually have an example that you can follow. So there are actually 8 examples. And next slide, please. So this is an example of the examples that we have. And so we pulled out the Northwest example that was in there, and that's with regard to your outreach team, which is a very exciting initiative, really helping to, first of all, address the vacancies that are in several of the communities where there are local PT and OT vacancies. So by having this outreach team being able to go there, we're addressing that, to be able to provide a shared care model where the OT and the PT can then provide input to those kind of generalist physios and OTs that are working within the community, to then give them information with regard to kind of specialized rehab provision. And so it's really providing care to those who likely would have a very difficult time being able to travel into like a bigger center, and really allowing that shared care support for the home and community care services and primary care rehab providers that are in those communities. And so I really like this quote. It is a 3-hour drive to go to the next closest rehab facility, which is a long way to go for a half-hour appointment. I would not have traveled. So this is actually, we talk about health equity. Well, this is actually getting services to a place that might not have had that service in any other way. Next slide, please. Okay, so these are the outcomes based on the quintuple aim. And we just talked about that advancing health equity, and we don't actually have data to support that yet, but boy, it will be good to get that coming. So I believe that's underway to think about that, because this is definitely something that I believe we can tell is advancing health equity. But there are also some really amazing other pieces that are being measured. So patient experience. We know that 54% of clients report no access to rehab if it was not provided locally. And client satisfaction, 100% showed that they reported that they they were very satisfied with the services that they were receiving. And so in terms of population health, we've seen improved access. We talked about this already. So many more visits happening that would not have happened otherwise. In terms of value and efficiency, we've improved wait times. So, 90, you know what, my screen, I can't even read it, but you can see it there. Lots of wait time days that are being reduced, and lots of cost savings that are happening. So, and then for care team well-being, this is really helping to address HHR shortages and providing mentorship to be able to meet those regulatory requirements so that some of our newer grad physios and OTs can be hired, and also allowing for this shared care model that we were talking about. So I think that's it. Next slide, please. Oh, nope, sorry, my bad. So in terms of next steps, oh no, next slide. Thank you. So our next steps are really going to be to look at an environmental scan of so patient-reported outcome measures and patient-reported experience measures that are currently being used in community-based rehab across Ontario. And this will help to inform maybe a more standardized approach that will then help to inform our data collection, which we would really like to see a more standardized data collection, and that's actually part of the recommendations that have gone out to OH and the Ministry of Health and will be going to the OHTs. And we really want to also be able to provide support and direction to OHTs to include community-based rehab at their tables and within their core services, because we really need to be positioning rehab care as part of that solution for how rehab care professionals are in service of the population. So we know that we reduce wait times. We just heard about that. So we support flow, we keep people healthy and at home and maintain their function and support primary care. So we need to really kind of help to position this within OHTs. And now I think that's it. And I guess, Carissa, are you rounding us out here?
No, I'll save any final comments for the end, but happy to take any questions.
Perfect. Well, thank you so much, Carissa, Katie, and Gabrielle for today's presentation. And thank you for all the work that you've put in for the North. It is definitely needed. So we're just going to open it up for questions. If anyone has any questions, feel free to take yourself off of mute or put it in the chat.
If I could just add a comment to your last point, Jennifer, while people are thinking of any questions, I just wanted to highlight and it's, the Rehab Care Alliance, we're a small secretariat, and so we can only accomplish what we do through the unbelievable engagement of stakeholders. And just to acknowledge, I know we talked with Denise and acknowledged Denise throughout, Allison Denton, Dana Corsi in the Northeast, Nicole Gallagher, like really strong rehab champions that have been working with us collaboratively to create a number of these initiatives and engage local providers and move them forward. Because as a provincial organization, we only have so much capacity, and so it's through that active engagement that we can really move things forward. So I just wanted to thank those people and acknowledge them.
Thank you, Carissa. Any questions?
I have a quick question. I first of all want to make sure that everyone on this call goes to your website, because there are some incredible resources and guidelines there and updates on the work that you're doing and archived webinars. It really is an incredible resource. And I wanted to ask, I guess, a specific question about the post-fall pathway. You talked about some ongoing work that you're doing with that, but if a site was actually interested in starting to look at implementing that at their own site, is there any support that the Rehabilitative Care Alliance can provide, or some guidance? Is it too late to get involved in the evaluation that's going on?
No, not at all. So we are actually quite open for other organizations, OHTs, regions to be able to move toward the implementation of the post-fall pathway. What we at the Rehab Care Alliance can provide is we're providing project management support for a period of 1 year, which then helps to be able to roll out that implementation. And we can provide you with all of the tools to be able to support that. So things like the data collection, data analysis, and actually working towards the adaptation of the pathway to your local context. Now in Thunder Bay, we've actually done this already in collaboration with Denise and Allison and all of the amazing people at St. Joe's and at Thunder Bay Regional, as well as all of the partners, because to be able to roll out this pathway, it really is a full region endeavor. It can't really actually be done at one organization. It's something that takes into account all of the different community-based programs, both for specialized geriatric services as well as rehab. And Denise, have I covered it, or is there anything else you would like to add?
I just wanted to add that if anyone in the Northwest, a region or community in the Northwest also wanted to implement that falls pathway, that myself and Allison would be there to support that as well. So Rehab Care Alliance for sure for the project management, but that is a local goal to be able to spread that out. We didn't ever mean for it to stop in the city of Thunder Bay. And partly because, I mean, Katie was kind on the system evaluation. We do really well in the Northwest for a couple of the indicators, but the indicator we are the worst performer in the province is the repeat ED visits for falls for people over 65 in the community. So it is certainly continues to be a priority.
Thanks, Denise. And I just want to say that there is no way that we could roll this out without those feet on the ground. And Denise and Allison have been our champions and amazing. So thank you.
Thank you all. I know we're very lucky to have Denise here in Thunder Bay. Any other questions? Rock, you always seem to have questions.
Hi, Jen. I've got lots of questions, but don't want to get into too much trouble. I do have a question. We have been hearing about a lot of discrepancy through the province in terms of rehab available to people, particularly into the home care sector, which may also reflect different funding models and approaches. Is that something that the Rehab Care Alliance would track or be monitoring?
Hi, Brock. I can start and then invite Katie and Gabrielle to chime in if they have anything else to add. So funding is a little bit outside of our scope. We certainly contribute to conversations around funding where we can help to illustrate the connection between funding models and access to care, whether it limits or enables access to care. So we do participate in some conversations around that, whether it's with the OHA, Ontario Hospital Association, or others. I do know that through the system evaluation performance scorecard that Katie leads, we do track regularly as one of our benchmarked indicators wait time to access rehabilitation through home care. And if you, our report will be published shortly, So if you sign up for our newsletter, you'll get access to that report that's coming out. But you'll see in that report that there was a significant increase relative to the previous year. So last year, there was quite a significant increase in wait times for access to home care. I think, Katie, right across the province, I mean, certainly some regions there's variability, but a noted increase in wait time for rehabilitation. We are hearing that as well from providers that as we hear, you know, it used to be alternate level of care was the one consistent point of discussion I heard at any meeting I was ever at. Now that's bumped down to the second. The first is health human resource shortages. So I'm hearing that in every region of the province, and home care is certainly not immune to that challenge as well. If I can just pick up on that last point, I'll highlight as well Carolyn Freitag, who, as you all know, is a VP at St. Joe's Care Group in Thunder Bay, will be joining us for a panel discussion on health human resource issues at a conference on May 5th. So happy to promote the good work that Carolyn and her team are leading. So Brock, I don't know if that answers your question, but Denise, I see you've come off mute if you have anything else to add.
Yeah, I would just say, Brock, that Katie actually shared, you don't have to wait for the report. So Katie actually shared all of the Northwest system data at our February advisory committee meeting. So you do have those in that package from the February meeting. But it is just by the whole region. So it doesn't break it up for the subregion specifically. So I know that the Kenora area has had more of an issue with wait time for home and community care, and that would need to be through the home and community care programs, and they are, I believe that they are aware of that.
I'll tack on just one more thing with respect to those wait times. And looking at the dashboard and the report, especially around wait time for in-home rehab, just keep in mind that a lot of organizations have prioritization tools. And so if there were priority patients for home care, they may have been seen within the required time wait. However, within this report, it sort of gets all aggregated. So you sort of don't understand the wait time for those prioritized patients versus not. So just keep that in mind when you're looking at it. But as Chris mentioned, the wait times were really significantly raised across the province.
Thank you so much. Any other questions, Brock?
No, that's great. Thank you very much.
I had a quick question for Katie. You were talking about the environmental scan that was I recently worked on, and I remember reviewing a draft. Is there a plan to publish and disseminate that in the near future?
Yes, Mike, you watch for the newsletter to come out, and once that newsletter is out, it'll mean that the workforce environmental scan is posted on our website. It's in the very final stages of being finished, and I can't wait to get it out there. I think it's a really great snapshot of what's happening. It's a very dynamic time for workforce, as you guys can probably well appreciate. And as I was writing it, things were changing. So really, it's up to date as of March of 2023. But you know, really feel like it's a good start of just sort of looking at what's happening right now in the province, and certainly, hopefully, it'll start to direct the building of the strategy. But I think there's some really great strategies that are already happening in the province, and we just need to sort of elevate those and think about, you know, how we can really action them in the year to come.
Thank you. Any last questions?
Just a comment as well, I would, and thank you for the comment in the chat, I believe. But just to highlight that some of our initiatives, they're not all, you know, top down. Many of them are not top down. A lot of our initiatives are identified by regional stakeholders to say, this is an issue for us. Can the Rehab Care Alliance help us with this? Can we do some work on this? So I would certainly invite anyone that has rehab specific issues or needs, or, you know, thoughts about what can the Rehab Care Alliance think about working on, please reach out to us. We're really always interested to know what would be of value. How can we help to support the work that you're doing in the Northeast and in the Northwest? So chances are, if you have that thought, others do too. So appreciate any and all reach outs.
Perfect. Thank you, Carissa. So on behalf of NOSM University, I'd like to say thank you so much for today's presentation. We're very fortunate to have the Rehabilitative Care Alliance. It's such an important resource for all of our rehab clinicians. So if you're on the call today, please share it with your colleagues, and their website, their dashboard is fantastic. So thank you again on behalf of NOSM.
Thank you. One last plug, actually, for our upcoming conference in Thunder Bay on May 12th, Northern Connections, where Denise and her colleagues are actually going to be presenting on a number of the topics that were discussed and brought up today around the post-fall pathway, the community rehab worker program, and the outreach program. So certainly an opportunity to learn more about those and discuss those with Denise and her colleagues. So thank you very much. We truly appreciate the webinar and the sharing and discussion today.
Thanks for having us.
Thank you.
Thanks.